Welcome to the webinar on healthcare systems engineering. I am Bo Oppenheim. I serve as the director of the Healthcare Systems Engineering Master's Program at Loyola Marymount University. The photograph that you see here is a view from our campus to the Pacific Ocean. This webinar will follow this outline. I will start with how it all started, the big milestone, the so-called 2014 PCAST report published by the White House. Then it's good to review the imperfect state of US healthcare, in other words, to list the challenges that we need to address, or as many of them as we can using this new body of knowledge. Then I'll define the term systems engineering. What is it, where it came from, and why do we think it applies to healthcare? And section 4 is the longest. In this section, I'll march through the elements of healthcare systems engineering, defining them and explaining how they are aiding the healthcare industry in a very powerful way. Section 5 is a brief section. I'll describe our master's program at Loyola Marymount University. We developed this program in partnership with Kaiser Permanente. And the block in blue is, of course, the webpage address of our program. It's a very comprehensive webpage. I would like to invite you to peruse it. We have some videos by experts. We have a complete description of the courses. We have a list of the student projects, capstone projects completed so far, and a lot of other good stuff. And of course, a summary. So without further ado, in 2014, the White House published this report referred to as the PCAST report. It was published by the President's Council of Advisors on Science and Technology. Here is the cover of that report. And the most important message from that publication is listed here, quoted in blue, namely that systems engineering know-how must be propagated at all levels of healthcare. So this is how it started. Let's review the healthcare in the United States. So obviously we have fantastic islands of excellence. We have great medical education. We have great dedicated providers. We have fantastic facilities, we have fantastic research, fantastic equipment. However, in aggregate, when we look at statistics, the picture is not very pretty. Our costs are 2 to 3 times higher than in the next developed countries. This table compares the cost in this line, the lowest line. We still have about 13 million people without medical insurance. About 250,000 Americans die every year from hospital infections and medical errors. Up to 400,000 people die from preventable death in hospitals. That includes about up to 80,000 from diagnostic error. The medicines are unaffordable to 100 million people. About 1/3 of US adults skip a recommended test or treatment because of cost. We rank number 70 in wellness, which is primarily due to the obesity and diabetes. And we rank last among the 11 countries listed here on this graph in preventable death. So clearly there is room to improve our healthcare. This is a short list of healthcare problems, and almost all of them will be addressed by healthcare systems engineering. So obviously we have a very highly fragmented system, fragmented on many levels, in many dimensions. We have very inefficient interfaces and handoffs, lots of dropped balls, such as the abnormal test result not being acted upon. Burnout of providers is a serious problem, where the overall healthcare becomes vastly more complex in a geometrical progression, which is conducive to errors and accidents. The bureaucracy is huge, robbing providers of useful time with patients. We still have wrong incentives present, which inflate healthcare costs. Revolutions are happening in a lot of healthcare areas, in population health, prevention, and chronic care. home health, telemedicine, big data mining, biogenetics, AI, IT, medical equipment. All of those revolutions open extraordinary opportunities, but also present very big challenges, complexities and challenges. We have geometric progress in medical devices, and they present interoperability challenges because now the instruments, the devices need to be cross-connected and talking to computers, to databases, and so on. We still have huge waste in all operations. At the same time, when we have shrinking budgets and operations such as OR, emergency departments, pharmacies, are getting increasingly complex, and those require simulators for training of stakeholders and for analysis. So it's obvious when we look at this list that neither traditional medicine, nor the MBA education, nor the Masters of Public Health or MPH education equips graduates to handle those challenges. It's the healthcare systems engineering that does it directly. So let's go back to the basics. What is systems engineering? It started in the 50s in the US ballistic missile programs, when very smart people realized that we cannot leave the design of those very dangerous systems in the hands of disciplinary experts alone, such as mechanical engineers, electrical engineers, aerospace engineers. And they realized that a new body of knowledge is needed to make sure that the individual pieces, individual disciplines work together properly. So systems engineering is a holistic interdisciplinary process that assures that a complex system is designed, integrated, and managed properly. The emphasis on integrated, on putting together the individual fragments. At the same time, maximizing system quality and safety. Systems engineering is a standard process now in all military and aerospace and increasingly infrastructure and energy programs. Interestingly, even though it's called engineering, it's a mostly non-mathematical body of knowledge. It's more akin to management, except that it's a very rigorous, very precise type of management. Why do systems fail, complex systems? It turns out that failures happen very rarely because of the lack of competence of individuals working within their disciplines. So we have very competent doctors, we have very competent nurses and so on, and yet it's the fragmentation that kills. Highly fragmented complex systems almost always fail at the interfaces, at the connections. Interfaces between silos, silos between departments, cooperating institutions, interfaces between humans, because people are rushed, they do rushed communications, the handoffs are imperfect, and interfaces between people, processes, hardware, and software. And if we don't use systems engineering, then we end up with bridges looking like this. And we know from our healthcare experiences that this is not an uncommon sight in the healthcare context. I would like to invite you to a mental exercise for a minute. Just consider the simplest possible system, and that's one consisting of two elements. There is only one simple connection possible, right? If I increase the number of elements to 5, and draw the possible connections and count them, we get the number of 10. And obviously the general formula is this, n times n minus 1 over 2. In other words, it's a quadratic function in the number of the elements. How many elements do we have in healthcare? Well, let's look at this example of healthcare. Suppose that a patient comes to a clinic, to a primary care physician, with some medical complaints, and the physician is not quite sure what it is, so orders some labs, clinical labs, perhaps an imaging lab, perhaps an X-ray or a ultrasound, perhaps sends the patient to a specialist. Obviously, some nurses are involved, The electronic health records are involved. In more serious case, the patient may be sent to an emergency room, the hospital. So here we have a simplified list of the stakeholders or stakeholder groups involved in the simple case of diagnosing and treating a patient, right? 9 elements, and it's simplified because each of them actually involves a number of people. So now when I take the 9 elements and list them here in this matrix as rows and also as columns, I get 81 fields, and each field really represents an opportunity for dropping the ball, for something bad happening, the bad interface between one of those elements and one of those elements. I chose to continue this example right here when we have the interface between the primary care physician, PCP, and the clinical laboratory handling the test. Okay, so the PCP ordered the patient to take to give a sample of blood and expects the results. And what happens? Well, let's see what can possibly happen. We now expand the problems at the interface to all problems that we can identify. Again, keep in mind, this is a simplified list. I could easily make it 5 times more complex. So the one element is that the patient failed to go to the lab, okay? How likely is it? Doesn't happen terribly often, but does happen. The impact of this could be severe if it's a serious medical condition and the patient doesn't get diagnosed properly. So the mitigation listed in this column is to positively check with the patient, reminds the patient if necessary. Another problem could be that the sample is untestable, perhaps was placed in a wrong container, it was handled incorrectly, transported in a wrong temperature, wrong label was placed on it, and so on. Well, in that case, again, doesn't happen very often. The impact could be severe. So what we need to do here is to contact the patient for a repeat test. Similarly, when we lose the blood sample in transport or in the lab, again, doesn't happen often, very rarely, in fact, but does happen. The consequences, again, could be severe. So again, we need to contact the patient for a repeat test. Next potential problem is that the test was performed but not resulted. Perhaps they lost the power in the laboratory for a minute, and thus the communication with the computer failed. The likelihood, again, is low. The impact could be severe. We need to chase the result. That's the mitigation, right? Next one, test was resulted, but there was no feedback to the ordering physician. Again, doesn't happen often, but does happen. In fact, it's one of the most serious problems with abnormal tests being abandoned, not reacted upon. The remedy here is to improve the electronic records, to provide some kind of an alarm to the provider saying, hey, you did order this test, you never received the result, okay? Act on it. Abnormal test was not flagged as abnormal. It was resulted, it was sent back, but was not tested, was not flagged as abnormal. Again, doesn't happen often. The impact could be potentially absolutely critical. Patients die from it. So we need to, again, implement electronic flags about abnormal test results. And the last one listed here is that the ordering MD received the test results, received all the information about it, but failed to follow up, perhaps was exhausted, perhaps didn't feel very well, perhaps had troubles at home, and so on. The likelihood actually is not that rare. The impact could be very severe. Okay, so we need to make sure that automatic reminders go to the MD. So you see, this is how we handle each single interface. We list the problems, likelihoods, impact, and the mitigation, and then we act on the mitigations, we implement the mitigations. Consider the numbers. A clinical laboratory performing 30 million tests per year and managing them at the level of 99.9% correctly still leaves about 30,000 tests not managed correctly, with tremendous dangers, risks in consequences. So systems engineering approach is to systematically, carefully evaluate every possible interface in both directions, identify the issues, risks, likelihood, impact, and formulate mitigation requirements, and then implement those mitigations to integrate the care seamlessly. Again, I think you will agree that neither traditional medicine nor traditional management are sufficient. And this is bread and butter for healthcare systems engineering. This slide differentiates the three domains of education: the typical MBA, typical MPH, and healthcare systems engineering. So MBA nowadays tends to focus on finance, on accounting, on marketing, on decision support. The MPH tends to focus on high-level health issues, very critical issues, but they are high-level, national level, such as environmental health, such as infectious diseases, aging, child, adolescent, women's health, and so on. The MPH education does not typically deal with actual operations in clinics, hospitals, EDs, ORs, and so on. It's the healthcare systems engineering. So healthcare systems engineering elements include the basics, such as systems engineering process, project management, and systems thinking. And then we focus on integrating fragmented healthcare elements. Lean is very much an established body of knowledge in healthcare systems engineering. It has the power to streamline healthcare processes and eliminate wastes. We focus on patient safety systems and quality systems, with the emphasis on the word systems. We focus on IT, integrating providers, patients, devices, and processes. We focus on modeling and simulations of complex processes. We focus on expanding the population health capabilities, which includes home care, preventive care, precision care, chronic care, and so on. We focus on big data analytics, and we focus on the integration of medical devices into the overall care. Typically, healthcare systems engineers do not design medical devices. It's the mechanical and electrical engineers and medical professionals do that, but they are involved in integrating the devices into the care. Similarly, in the IT area, the healthcare systems engineers do not code the software, but they provide requirements needed to integrate those elements: providers, patients, devices, and processes. So you see from this slide that indeed it's the healthcare systems engineering which has this very good focus on the challenges of healthcare operations. This is a long quote, but very profound, from Dr. Michael Kanter, who is the executive vice president of Kaiser Permanente. He's the vice president for patient safety. Soon he's transitioning to the position of associate dean of the new School of Medicine. So please bear with me as I read it. Many industries have used systems engineering to improve reliability, safety, efficiency, and effectiveness. Healthcare, however, has been late in embracing systems engineering despite the potential to help fix what is basically a non-system of care. Although healthcare can do some amazing things, anyone working in healthcare has also seen examples of suboptimal patient outcomes, unaddressed patient safety issues, poor reliability, and inefficiencies. Traditional medical thinking is not well equipped to improve many of these problems. Much of this, however, can be addressed if systems engineers, physicians, and healthcare professionals could better collaborate and use well-known systems engineering techniques. So indeed, profound words. Dr. Kanter serves on our board of advisors, I should mention. So now let's look at the healthcare system engineering elements, and let's describe the power of those elements in curing the ills of healthcare. So already you have seen this list on the previous slide. Those are the focus areas of healthcare systems engineering. The focus is definitely on operations in all of those areas. The first one is the project management and systems engineering process. Systems engineering process is somewhat similar to the project management process, but is more detailed, much more rigorous. So the engineers here are trained in the process, in project management and systems engineering processes and tools. They are really good at it. They must be good at it. The list here is from 1 to 20, contains a list of the systems engineering process. It includes the capture of the need, project management, the version practiced by systems engineers, systems thinking, capture of the value. A lot of projects start without properly capturing the value, and then they go south, as we all know. Development of use cases and scenarios, formulation of good requirements, and the emphasis on good. Requirements must be formulated properly in order to yield a good result. Allocation of requirements to departments and individuals, selection of performance metrics, designing system architecture, definitions of candidate solutions and measures of effectiveness, and then selection of the best candidate. Again, too many people jump to conclusion without really evaluating different candidates. So in systems engineering, we do it properly. Modeling and simulation is a process. Risk management, quality management and patient safety systems, designing, optimizing and building system elements. Integration is hugely important. Integration of the individual fragments, we discussed it already. Then evaluation of performance, verification and validation of our solution, of our system. Operationalization, meaning training of the stakeholders, preparing training materials, disseminating the knowledge. Model-based systems engineering is a tool, is relatively little popular in systems engineering. It has to do with a kind of graphical mathematical modeling of how the information flows from element to element. And then we have the complex adaptive systems and Lean and Six Sigma. So those are the elements. In this project, I conducted interviews with high-level executives from Veterans Admin, Kaiser Permanente, Providence St. Joseph, Children's Hospital of LA, Sacred Heart, and Maine Health. And I asked each, I explained first the processes, then I asked each to please rank the use of each process and the importance of each process in your area of work, in your organization. So let's compare the numbers. The ranking goes up to 5. So 5 means yes, maximally use it all the time, or it's very important. Notice that in all cases, without exception, the importance far exceeds the use. That means the stakeholders confirmed that systems engineering is important, but it's not used as much as it should be. And the differences are quite dramatic. Okay. The only 2 processes which received lower ranking are the model-based and complex adaptive systems. In all other cases, we see this dramatic difference. So this chart alone is a solid confirmation that we need to use healthcare systems engineering in our healthcare operations. Systems thinking teaches how to think big, how to think holistically about system challenges and opportunities, how to watch for unintended consequences and emerging properties, how to identify and coordinate all relevant stakeholders, and how to validate solutions. So we do it well. Lean, obviously. Lean is now an established body of knowledge practiced in practically all healthcare facilities, organizations. Those are the 3 famous books on Lean. The last one is mine. Here is the illustration of the Lean process. So I'll skip that because it's a well-known well-known process. Let me jump to the description of how we teach Lean. So we have two courses. The first course is in basics, taught by a fantastic fellow and expert formerly from MIT. And I teach the second course. And in the second course, we cover in minute detail the problems and the solutions, Lean solutions, improvements in all of those healthcare operations, in clinics, hospitals, EDs, ORs, pharmacies, clinical labs, imaging labs, and supply chain administration. I'm proud to say that LMU is recognized as the top center of Lean expertise in all above healthcare environments. Our history of Lean goes back 20 years. We partner with MIT and with industry. We did consulting, Lean consulting at about 300 institutions. We saved millions of dollars, and we really know how to do it well, efficiently and effectively. Patient safety systems. Okay, here we look at the death and injury due to errors in healthcare and what needs to happen to prevent those. We look at the reasons for diagnostic and treatment errors, and then we focus on leadership for patient safety, on changing the culture from the blaming and shaming culture to trust, openness, teamwork, honesty. We focus on performance standards and expectations. We focus on creating safety systems and creating medication safety systems. Given the high numbers of victims of our errors and the preventable death, it's clear that healthcare desperately needs a systemic approach to patient safety, and healthcare systems engineering provides that. Now, this illustration is well known. It's repeated after J. Reason. It illustrates an example of a nurse who prepares to administer a medication, but her challenges are that different medications are stored in look-alike bags, and there are no warning labels on dangerous medications. So this arrow, which represents the error, okay, this error propagates through various filters which should have been there, but were absent, and the patient received the wrong medication and has a respiratory arrest. So in the ideal system, we must design a number of those safety barriers, safety filters, such that if one fails, the next one acts and the error is not supposed to occur. In other words, we make imperfections impossible to occur. That's the whole idea here. IT. Again, it's supposed to integrate providers, patients, organizations, devices, processes, payers, plus lately internet-based care. A lot of people say that there are big problems in the current electronic health records. The rhetorical question they ask is the health IT tail wagging the dog? We all know that EHR started as a tool for billing. Now we need integration of fragmented healthcare using IT, for example, to assure a good follow-up for every abnormal test. Also, EHR is needed as to provide data to big data studies, to big data analytics. In this, we have a tension, a very strong tension, competition between, on one hand, the desire of the researchers for increased granularity, increased information, and researchers needed regulatory bodies and actuaries. On the other hand, it means increased workload by providers to enter more data into the EHR. So we need to constantly balance that dichotomy. We need to resolve ethical issues in using IT. The good IT should migrate towards more and more computer-aided diagnostic tools, which means capturing the body of knowledge of medicine, simply because we cannot continue to rely on the brain and cognitive processes of the medical professionals. There is too much information, too much changing information for that. We need to pay attention to data integrity, cyber protection, telemedicine, issues of privacy, payments. So again, healthcare systems engineers expand this knowledge, they provide the support for IT projects, they formulate requirements for IT projects, and it's a very important role, and it will be an increasing role. Just a little example, I'm grateful to Dr. Kanter for this slide. Before Kaiser Permanente implemented what they call the complete care, they measured absolutely horrifying statistics. Let me read some of them. 44% of abnormal FOBT tests, those are the blood testing for colorectal cancer. 44% of abnormals were not followed up in 5 years. 52% of abnormals creatinine tests were not repeated after 90 days as they should have been. 25% of death occurred because of ruptured aneurysm, and this was because of the failure to follow up on the patients already known to have the aneurysm. The elevated PSA levels were not evaluated by a urologist within 12 weeks of receiving results. So the results were received, the tests were done, but not followed up. In oncology, the integration of this large number of stakeholders was very poor, and the ball was dropped. So then they implemented the system based primarily on the IT. They call it complete care. And those numbers went dramatically down, dramatic improvements. So indeed, good IT system offers huge potential in improving population, preventive, and chronic care. Simulators. We increasingly need more and better simulators simulating the activities in the operating room. And this is a visual, one of the visual simulators on the market. Activities in the emergency departments. We also now develop stochastic models. For example, this is a representation of a stochastic model of emergency department. We begin by drawing the process map of the flowchart of how the patient moves through the system with different decision points. Then based on past statistics, we allocate probability functions to those decision points. Those are the probability density functions. It's not difficult to do. And then we do what's called the Monte Carlo analysis, namely we simulate a large number of patients, perhaps 1 million patients going through this with those random events. And the result tells us what is the throughput time per patient, what is the capacity of the ED, and we can play what if games, such as what happens if we remove one nurse, or what happens if we add a nurse, or if we add a provider, how much will the capacity increase, how much will the throughput time decrease. So those are very elegant, very powerful tools of systems engineering. Systems engineers also perform a lot of analysis, such as statistical process control, metric analysis, statistics and regression, operations research, optimization, support for medical research projects, and support for general science. So strictly speaking, those elements are not parts of healthcare systems engineers, but most healthcare systems engineers are familiar with most of them, if not all of them. Big data analytics is another fantastic potential. Look at the number of medical records we now can access. At Kaiser Permanente alone, 11 million medical records, this many patients. In the US, 300 million. If we could connect to the global population, we would have about 9 billion records. So with those many numbers, we can now perform very powerful data mining, powerful studies of correlations, and of simultaneous effects of numerous factors, complex iterations. We can isolate the effects of intervention factors and so on, and build potent treatments. This is just an example of a list of the factors affecting cancer. They are divided into personal factors such as height and weight and age, smoking, lifestyle factors, sexual behavior, chewing, alcohol, and so on, environmental factors such as exposure to environments, weather, and inherited factors, genetic factors. Okay, and we can do very powerful studies correlating those factors with intervention factors and others. Medical devices. There is a geometrical growth now in the complexity of medical devices. They vary from miniature, such as the eyelid glucose sensor, to huge, such as MRI and operating room robots. So what we do very well is we capture the requirements for medical devices, we select the medical devices, and most importantly, we interoperate them, interconnect them to databases, to automatic computers, and we also deal with alarms and alarm fatigues. So healthcare systems engineers are very good at integrating the devices into the overall care. So what I just covered is basically a cross-section of the different subdomains together known as the healthcare systems engineering. And at the same time, those are the courses that we teach in our program at Loyola Marymount University. Again, this program was developed in partnership with Kaiser Permanente. I really would like to invite you to spend a few minutes looking at this webpage. It's a very comprehensive, hopefully attractive webpage. It describes everything which is relevant to our program. Also some videos by experts and also a list of student projects and the admission criteria and graduation criteria. That partnership with Kaiser Permanente was started in 2012. We jokingly refer to it as a partnership of the best, but we really mean it. We started with a graduate certificate in lean healthcare. We selected Kaiser Permanente because of their top national rankings, and they selected us because we were a national leader in lean and in comprehensive healthcare. Kaiser helped us in formulating the curriculum for the master's program. Interestingly, the new Kaiser Permanente School of Medicine is interested, we are now talking to them, in sending their medical students to us to obtain their master's degree in healthcare systems engineering, probably between the 3rd and 4th year of the medical school. And we have extraordinary experts teaching in our program from Kaiser, from MIT, UCLA, Stanford. They teach and they serve on our board of advisors. The board keeps me, the director, on a short leash, making sure that the program is the best in the nation. Also, we get a lot of capstone projects from industry, most of them from Kaiser. This red sentence, the first sentence comes from actually Oscar Wilde. He said that imitation is the sincerest form of flattery. So we just learned that Tsinghua, which is the best Chinese university equivalent to our MIT, thought fit to copy our program, our healthcare systems engineering program, almost verbatim, and we are delighted they did. You know, healthcare should not be patented, healthcare should be shared, that knowledge should be shared. That's our philosophy. We are now establishing partnership with Tsinghua in terms of student exchanges and faculty exchanges. A few words about our master's degree. The courses I already listed. This is the only such program in Southern California. Our graduates are very highly regarded by healthcare employers. They are in high demand. It's a one-year program, can be done at a slower pace, but is doable in 1 year. It requires 10 courses. The cost is $38,000 total. Each course is taught once per week, one evening per week. Some courses are online, and we are trying to increase the number of online courses. I would like to invite you to contact the LMU Career and Professional Development Office. Here is the email, to schedule interviews with our graduating students, to attend graduate fairs, and even to observe classes. You are most welcome to come in and observe our classes. Of course, we would love to get your employees to obtain this extraordinary education. You will be happy with the result. The costs are not that high. It's a good investment. And also, we always are in need of student capstone projects. So if you have a project to execute, please contact me. Again, this is our webpage. To summarize, neither medical skills, nor MBA, nor MPH education are sufficient to address modern healthcare challenges. It's healthcare systems engineering that does it, and there is an immense need for this knowledge. We look at ourselves as a service. So we don't order medical doctors, providers, nurses how to do their job. We don't tell them how to treat patients. We free them to do it better and more. Our comprehensive master's program was developed with Kaiser Permanente. It's a high caliber program for high caliber students directly addressing the industry needs. Please disseminate this presentation freely, intentionally. It's not copyrighted. Send this presentation. It will be posted on our webpage. Send it to everybody you think fit. I would only be grateful for that. Thank you so much for your attention. If you would like to contact me, here is my email and phone. I work at the Westchester campus, and again, here is our webpage. So I'll be delighted now to answer your questions.